neutrophils, the appendix, the Peyer's patches, and the lymphoid follicles. So these organs are rich with lymphocytes. Okay, so this table will just give us the relative distribution of the cells, the T and the B cells in the different tissues in man. So please take note where the T cell predominates and where the B cell predominates. The next table, these are the distinguishing properties of your T and B cells, so how they are recognized. This is more important laboratory lab purposes. Okay, how they are classified, how they are distinguished, whether this is B or T cells. So this is more of nice to know. So how they are identified in the laboratory. And then these are the functional properties of your T and B cells. So please take note of the function in which they are associated. Like for example, the killing of target cells. So mas damo itong identified nga functional properties of T cell kadamo man liwat itira ka population or kinds, diba? I have mentioned it earlier. We have the T suppressor cell, the T helper cell, the T killer cell. So those are some of the examples of the population of the T cell. So the one that is responsible in killing uh, uh, target cells, of course, we have the T killer cells. So as to the carrier specificity, so it is related more on T cell. Kaya itong B cell, again, the end product of its activation is antibodies. So it is more related on the receptor. Okay, so those are just some of the functional properties. I hold you responsible na to know each of the different properties. Okay, now let's go to the cells of the immune system. So the cells of the immune system usually is derived from the hematopoietic system, meaning from the bone marrow itself. Then the monocytic or the mononuclear phagocytic system, then the granulocytic phagocytes and the lymphoid system. So this include already the different tissues or organs that are identified as GALT. Okay, so with regards to the hematopoietic system, again, primarily the stem cell is uh, originated in the bone marrow. So from the stem cell, they will, if they are distinct to become red blood cells, so they first differentiate to become erythroblast, then leucoblast, and then the megakaryocytes for the uh, platelets. Okay, so we have first the mononuclear phagocytic system. This consists now of the blood monocytes together with the free and fixed macrophages in tissue. So it is the monocyte that differentiates to become macrophages. So from the blood, they are monocytes. So, and then when they already function as phagocytes, they differentiate now to become the macrophages. They represent about 1 to 3% of the circulating white blood cell in normal adult. And please take note that they stay only in the blood 1 to 3 days, and then they migrate to the tissues and become mature macrophages. And it is in the tissues that these macrophages divide and mature. So the lifespan in tissues may be months to years, and once they are already located in the tissues, they do not recirculate into the bloodstream. So once they are deposited to the respected organs, they do not re-enter into the blood circulation. So another characteristic of the mononuclear phagocytic system, they do not produce memory cells. Okay, so this is just an illustration, especially for the non-med decks. This is how the monocyte um, looks like. So you can best appreciate this in your uh, anatomical pathology when you will be doing your peripheral smear studies. So that is the characteristic of the monocyte. It is made up only of one nucleus. Okay. Then these are already the population of monocytes that differentiates to become now macrophages. They have now the phagocytic activity, the associated phagocytic activity. Okay, so let's go to the classification of macrophages. So we have the fixed and the free macrophages. So we have the free cells. They are usually associated in some of the cavities, body cavities in our body. So like for example, we have the peritoneal macrophages, the pleural macrophages, the alveolar, and the synovial macrophages. They are also located as sinus lining cells. So we have the Copper cells, the splenic, the lymph node, in the bone marrow. Um, Please take note that the bone marrow also have macrophages. And then we have tissue-specific macrophages. Like, for example, in the connective tissues, we have the histiocytes. Then in the central nervous system, we have the specific name for macrophages located in that area. We have the microglial cells. And then the mesangial cells, they are usually associated with the kidneys. Copper cells are usually associated with the liver. Okay, so these are the illustration of copper cells or the macrophages that are associated with the hepatocytes. Then we have the microglial cells in the CNS and the mesangial cells associated with the glomerulus in the kidneys. Okay, so what are the different functions of macrophages? So primarily, ito primary good na kuan na function is phagocytosis and antigen processing. What is antigen processing? This is a process of converting first um, the antigens into a highly potent form that is best recognized by the lymphocytes. So the antigen processing simply the conversion of the antigens para there is easy recognition by the macrophages. And then also the macrophages are involved in antigen presentation to antigen-sensitive lymphocytes, both your T and the B lymphocytes. So bagabara kira ito macrophages also as usherets. And then they function as also as secretory cells because when they are activated, they are responsible in producing cells also that they are responsible in producing secretions that participates, these substances participates in some of the inflammatory reactions. So they produce cytokines. So what are the substances that are produced by the macrophages in their secretions? So we have the enzymes. So example of this are the lysosomal enzymes. They add acid hydrolases, the lysozymes, and proteinases. Then also, aside from enzymes, they produce plasma proteins. So, like for example, your fibronectins, which are considered to be the universal opsonins. What opsonization is the process of coating that's part of the antigen presentation. So the antigen is being coated with antibodies para it would, with fibronectins, para it would be easy phagocytosed by the macrophages. So bagabagat hiyahin kung kuan pa inin icing para it is appetizing for the macrophages to ingest or phagocytose the antigens. Then also the macrophages produce coagulation factors and some of the complement components. And then aside from proteins and enzymes, they produce also the cytokines. Specifically, they are referred to as monokines. So this include interleukin 1 that is responsible in activating T cell and acts as an endogenous pyrogen. So interleukin 1 is responsible also for elevating your body temperature. So bagamagat hiyahin fever causing cytokine or inflammatory substance. And then also um, some macrophages are responsible in sensitizing interferons. These interferons are have been found out to have antiviral activity. Okay. Now let's go to the granulocytic phagocytes. Granulocytic phagocytes. So from the monocytes, this group of white blood cells are characterized by the presence of granules, characteristic granules in their cytoplasm. So we have the neutrophils, and it is also referred to as polymorphonuclear cells because of its characteristic shape of the nucleus. So it represents about 60 to 70% of the total WBC in the peripheral blood. This is the predominant phagocyte, but it is not capable of sustained phagocytic activity, unlike your macrophages. And they are not capable of processing the antigens. Half-life is about 12 hours, and there's an additional 2 days in the tissues. So in the cytoplasm, I have mentioned it earlier that they contain granules, and these granules are they contain now the enzymes. So the neutrophils, once they are elevated in your blood, it may signify acute bacterial infections. Okay, so this is the an example of neutrophils. So I hope you can appreciate this one. It is multi-lobe nucleus. So that is neutrophils. Uh, then we have the eosinophil. So it represents about 3% of the total WBC count, and it has been found out to be less efficient with regards to phagocytic activity. So basically, your eosinophils are increased in cases of allergic reactions or inflammatory reactions. It stay in your circulation about 30 minutes, and they can also be deposited in the tissues and stay there for 12 days. So the cytoplasm is it contains granules that have enzymes and eosinophilic proteins. Okay, so this is a beautiful illustration of an eosinophil. So please take note of um, the color of the granules that are contained in the cytoplasm, and this is responsible for the characteristic name of the cell, eosinophils, because it takes up the eosin stain contained in the stain used for differential counting. Then we have the last one, the basophils. It represents about 1% of the total WBC. It does not have phagocytic activity. So it contains the granules may contain chemical mediators like your vasoactive amines, like your histamine. So kung na-contain yan histamine, it may be involved in some allergic reactions. Okay, so that is your basophil. It is called basophils because of the color of the granules, because it takes up the basic dye that is contained in the stain. Okay, so the last one are the lymphoid system. Of course, the principal cells are called the lymphocytes. So I have mentioned it earlier that there are two classification of your lymphoid tissues. We have the primary and the secondary. Primary, this only include your thymus and your bone marrow. And then we have the peripheral or secondary lymphoid tissues. So example, of course, you have the lymph nodes, the gulf, the gut-associated lymphoid organs. Okay, so that is this is an example of a lymphocyte. So please take note, it has around nucleus surrounded with a little amount of cytoplasm. Okay, so uh, let's go now to the functions of the central and the peripheral nervous lymphoid tissues. So the central lymphoid tissues, namely your T, thymus, and the bone marrow, regulate in the production and differentiation of the lymphocytes. So again, I just would like to emphasize that the the stem cell all are derived from the bone marrow. They gain its name T cell because it undergoes differentiation in the thymus. So it is the site for the maturation of lymphocytes in the absence of antigenic stimulation. So there is no need for the presence of the antigen in order for these lymphocytes to mature. It is in the central lymphoid tissues. So they are responsible for the acquisition of the lymphocytes of its ability to recognize self and non-self antigens. So this refers to the different populations of your T cells. So the ability to recognize self and non-self, that's the function of the T suppressor cell. So again, we have the thymus, the bone marrow, the bursa of Fabricius, that is the bone marrow equivalent in among the birds, and the fetal liver. It has also contribution in terms of production of lymphoid tissues. Okay, I have mentioned this already. The thymus, so the thymus is said to be the master organ of the immune system. It is fully functional at birth, but starts to be atrophic at puberty. Sabihin ko pa kanina, um, during adulthood, it is now converted into a ligament at the back of your sternum. So this consists of mass of lymphocytes. Specifically, they are being referred to as thymocytes, and of course with epithelial cells. So, and primary cells are the that participates in the response are the thymocytes, which are basically the lymphocytes and epithelial cells. Please do not forget that there is also important function of the epithelial cells. So we have the precursor T cells, again are derived from the bone marrow and reach the thymus via the blood circulation. The purpose of this is for maturation and differentiation. Okay. So the T cells rapidly divide and differentiate in the cortex of the thymus, and my majority of these T cells die within the thymus. So diri pa nga niya ragin di-dispatch na to the target area for where the antigens are located. Dito pala ha thymus they die. So further maturation occurs in the medulla, where they acquire now the surface markers and the ability to recognize self-antigens. So these T cells recirculate in the blood and are then distributed to the different peripheral lymphoid organs. So may you will ask, Sir, kung ano, kaya rin naman thymus during adulthood, ano to? Don't worry, because the T cells are then and functions and thymus are then replaced by the peripheral lymphoid organs. And this is the one I mentioned earlier. Do not forget na may hapon functions and epithelial cells associated with your thymocytes. So what is the function of these epithelial cells? They are responsible in secreting hormone-like substances which regulate now the differentiation and maturation of T cells. Okay. So that is for the thymus. For the bone marrow, again, this is the functional equivalent of the bursa of Fabricius. So it is the site for the cell differentiation and maturation. Please take note that the bone marrow also contains macrophages. Hence, aside from being a central lymphoid organ, because of the mere presence of the macrophages, they can also be classified as a secondary lymphoid organ because of the presence of these macrophages. Okay, so what are the different peripheral lymphoid organs? So we have the lymph node. Hawari-waray, damo inin iton kuan, iton mother tongue. So lymph node pwede tiya lusay, okay, or larong na waray-waray, this mga bulugan, okay. These are round or bean-shaped organ arranged in lymphatic channels to filter antigens from the lymphatic circulation. So if you're going to cut cross-sectionally the lymph node, you can appreciate three regions. So we have the cortex, the medulla, and the paracortical zone or the deep cortex. So what are the cells that are located to these different regions in your lymph node? The cortical layer is made up primarily or predominantly by B cells. B cells. And then the medulla may contain macrophages and few T and B cells and plasma cells. So basically, ang medulla, macrophages, pero may nanaguti ay gihapon nga B and T cells. The paracortical zone or the deep cortex, this is the region between the cortex and the medulla. So it mainly contains the T cells. So itong arrangement from going inside a cortex is B cells, then it is being followed by B cells, and then the middle layer, the medulla, contains now the T cells. So that's the arrangement. Okay, so this is the cross section of a lymph node. Again, the cortical is made up of the B cells. Then we have the paracortical made up of the T cells, and the medulla is made up of macrophages and some B and T cells. Okay, then we have the lymphatic circulation. So the lymph node of flow through the thoracic duct. So at a rate of 500 ml per hour, and it contains about one raised to power no, 1 times 10 raised to the power of 8 cells per ml. So the lymphocytes enter the venous circulation, spending only 2 to 12 hours in the blood before returning now to the lymphoid organs. So one cycle is usually it takes about 1 to 2 days. It one cycle. Another peripheral lymphoid organ is the spleen. So the spleen, you know it already in your anatomy that it is located at the back of your, it is retroperitoneally located. So basically, the region, we have the red pulp and the white pulp. So the red pulp is mainly used for the destruction of aged or old red blood cells. In cases of hypersplenism, there is a tendency for the spleen to be active, and it will cause the sequestration of red blood cells that is responsible now for the anemia in cases of hypersplenism. Then the white pulp region of the spleen, this contains the lymphoid tissues in which they are arranged around a central arteriole called the periarteriolar lymphoid sheath that contains the T cells, whereas the B cells are just being scattered through the sheath as follicles. So they're separated from the red pulp by a marginal zone that contains macrophages. So that is the relative distribution of the T and B cells in the white pulp together with the macrophages. Okay, so this is your spleen again. The figure A represents the gross appearance of the spleen, and the picture B illustrates the cross section cut of the spleen. Okay, then we have the other peripheral lymphoid organs known as the GALT or the gut-associated lymphoid tissues. So the B cells are found in follicles, and the T cells that are found in between the interfollicular areas. So on your left of the monitor, we have the almost teasing tonsils. So pwede na niya grade 4 na enlargement of the tonsils. So usually this is seen in patients having tonsillitis. Okay. So Then we have the Peyer's patches. So, what are the cells involved in the lymphoid system? So we have the lymphocytes. This comprise about 30% of the total WBC in circulation. We have the T and B lymphocytes. And then we have also the so-called third population cells, or they are also known as the null cells or the non-T, non-B cells. They can also be derived from the bone marrow, but they are unclassified. So they usually represents the 9% of the circulating lymphocyte. By the way, in terms of size, we have the small and the large lymphocytes. But in terms of function, we have the T and the B lymphocytes. B will, no, in terms of function, will give rise to the production of antibodies. That T will do the cell-mediated reactions. Okay, so these are your illustrations of the lymphocytes. So uh, the T cell, and the yellow one, this one is the B cell. So please take note how they interact with the macrophage, the antigen presenting cell. So we have the Y-shaped antibodies. So these are produced by the B lymphocyte. Of course, the T cell may be involved in cell-mediated reactions. Okay. So the types of non-cells or the non-B, non-T cells, we have the large granular lymphocytes, also known as the natural killer cells. So they are characterized to possess the crystallizable fragment receptor, and specifically they function to kill target cells spontaneously or if coated with antibodies. The second one are the killer cells. So any cell, including your NK cells, macrophages, and neutrophils, which have the function in destroying the target cells, whether on the target cells that are being coated with antibodies. The process of coating the antigen with antibodies is called opsonization. So these target cells could either be tumor cells or virus-infected cells. So those are the two types of your non-cells, or the non-A, non-B, non-T cells. I think this is the last slide. Do you have any question? No. May the questions? Paray? May the padua ka topics. No questions, or you are already excited on my exam this afternoon? Actually, warek pa ako ka-kompleto iton fourth nga set. Pero tataliwaon ko makakatagapot exam iton alauna para waray na problema. Okay? No questions? I will proceed with the next topic. We have the sorry. Paray question? Uy. Waray moderator. Sige. Hindi kita sunod. Okay, what a question. I will proceed with another topic. We have the antigen-antibody reactions, the role of interleukins. I keep on mentioning this one. These are part of the substances being secreted by your inflammatory cells. And then, of course, the participation of the complement system. Okay, so now let's go to antigen antibody reactions. So what are these reactions? We have the precipitation of soluble antigens, agglutination of particulate antigens, then neutralization of bacteria, viruses, and toxins, and then activation of the complement system. Review. What antibody that is a good that has been found out to have good precipitating activity? What? Cesar? Immunoglobulin? Huh? So, immunoglobulin gamma or G. Very good. And so this means you cannot see. This is very important for serology liwat ini. And mas advantage ini liwat itong mga medtech. So there are antigens which are soluble. You cannot see. So just like doing your serological reactions, you cannot see the antigen. But if it is made to react with an antibody, there could be now a visible reaction like precipitation. So makakakita ka na may dakuan ngayon in reaction because of formation of precipitates. Okay? And then the second reaction is agglutination of particulate antigens. So example of a particulate antigen are are red blood cells, or there are some carrier molecules that in which the soluble antigen is attached para maging visible itong reaction. So, like for example, charcoal, colloidal charcoal, or the red blood cells. So, if it is made to react with an antibody that is capable of agglutinating these particulate antigens, then you can have a visible reaction. So, Cesar, ano nga antibody ito that has been found out to have a good agglutinating activity?
AGM the mu.
Okay, very good. So, the immunoglobulin mu. And then, of course, another reaction is neutralization of bacteria, viruses, and toxins. And then, participation in the activation of the complement system. Okay, so precipitation. It is an immunological precipitates. Ano to? It involved in the immunological precipitates that are said to be insoluble complexes formed by the union of antibodies and soluble antigens. So since we are referring to precipitation, we appropriately term the antigens as precipitinogens and the antibodies as precipitin. Okay, so during the formation of the precipitation of the precipitin, the interaction of your antibodies with that of the soluble antigens correspond to the formation of lattice. Okay, So reactants must be present in optimal proportion in order to build a lattice of sufficient size. So this means that for lattice formation to occur, there is a need that your antigen and antibodies must be at optimal proportion. Diri kuan kinanglan gud hirapadis in terms of concentration kay an may tatabo umag ka may ada in excess animo antibodies, there would be no reaction that will be formed. Kung excess luwat an imo antigen, what sufficient antibodies, dili gihapon magiging visible in imo reaction. So the primary requirement for precipitation to occur is there should be adequate concentration of both your antigen and your antibody. Is it understood? Yes, Dr. Esquivel. Okay. So, kay katuyo lang at gintagan lang kitang duha ka adlaw usa ka semester nga kuan subject. Okay. So, again, your immunoglobulin gamma is a good precipitating antibody. It precipitates are observed to form rapidly as temperature is increased to 40 to 45 degrees. So what enhance the reaction is the presence of temperature that is between 40 to 45 degrees. Yeah. What will happen if you go beyond the 45 degrees centigrade? You cannot see a visible reaction. Kaya ano? Kaya no nahitabo na if you go beyond the temperature beyond 45, ano't mahitatabo? Sige daw, Cesar. What will happen if kuan? Kita na lang tagi-istorya para may
Denature daw.
there would be
Denaturation daw.
very good. Since we are talking here of antibodies na protein in nature, so when you increase the temperature, you will be destroying now the antibodies. So it will cause now denaturation. Okay, so a dose response relationship is observed if if there is increasing amount of soluble antigen that is being mixed with a constant amount of antibody. So if you're going to plot it, you can appreciate three phases of precipitation curve. So we have the pro-zone, the zone of equivalence, and the post-zone. So you call it pro-zone when there is excess of antibodies, and then the post-zone when there is an excess of your antigen. You can better appreciate this one kung may ada naton drawing this one. Okay, so if you're going to plot it in on the graph, amit imo inihiya ma-iing ano ton, ma-appreciate. So in your y-axis, y, and the x-axis, so we have the antigen plotted against the antibody. So in the first ano ton, in the blue zone here, this is mas damo animo antibodies than the antigen. So this is your zone, pro zone. So there is ano an excess of your antibodies compared to the available antigen. Then there would be now ano equal interaction of your antigen and antibody. So you will enter now to the zone of equivalence. Zone of equivalence. And then when there is already consumption of the antibodies tapos na-increase pa ang imo antigen, so we have the post zone area. Okay? So that is the ano to, if you're going to plot the antigen against the antibody. So you can appreciate three zones: pro-zone, zone of equivalence, and post-zone. Okay? So we'll proceed now with another reaction, the agglutination. So this refers to immunological aggregation or clumping of insoluble particles. So this time, you are dealing here with an antigen that is visible to your eyes. So ano mo pa kung ano na para ma-identify the reaction is just may merely uh, made to react na i-clump hira or ano ton mag-form hiran aggregates. So the antigen is appropriately named as agglutinogen and the antibody agglutinin. Okay, so there are three major categories of agglutination reactions. We have the direct immune agglutination. This involves antibodies reactive with the antigen of the native particle. Typical example of this is your ABO blood grouping. So the antigen is found in the surface of your red blood cell. When you add the anti-sera or the anti-serum, the yellow and the blue anti-serum, so if there is clumping that is appreciated during the interaction, then you can identify, this individual is type A, type B, or type O kung absent an O substance, or if the two A and B antigens are present, then the patient is labeled as type AB. Okay? So it's through the use of the typing sera. Kung blue ang reaction, blue, ano, blue angel, yellow bird. So kung blue nga typing sera, nagkamay-ada reaction, clumping of the red blood cells, then the patient is labeled as type A. If there is clumping in the yellow anti-sera, so ang mahitabo, the patient will be labeled as type B. And then if there are clumping in both anti-sera, then type AB. If there's no clumping involved, then the patient is labeled type O. Okay? So we have also direct non-immune agglutination, meaning when you say non-immune, for the reaction to be visible, there is a need for the use of carrier protein or carrier substance, like or the utilization of um, plant extracts to make the reaction visible, like these lectins or phytohemagglutinin. So these are plant extracts that are capable of clumping your or aggregation of your red blood cells, or the use of the antigens from viruses. And then we have the indirect passive agglutination. There is agglutination of soluble antigens coated on the cells or inert particles which act as a carrier. Sorry, amo nga yan inihiyaan an akong ginisisig nga una nga there is a use of the carrier substance para maging visible its reaction. Sorry, iba an non-immune, meaning the use of plant extracts or other substances like the toxins produced by the viruses. Okay, so again, the immunoglobulin mu is a good agglutinating antibody. So quantification of the degree of agglutination is done through titration. So titration refers to the process in which the serum under test or in question is made up in a series of increasing dilutions, and each dilution is then tested for activity. So this involved making serial dilation of the serum. Gindidilute nimo iton serum, and then you note for the reaction to occur. So we have this term titer. We express pala the concentration of the antibody as titer. Na? Ito for the non-med text and the uh, non-medical an era preparatory course. When you say titer, this simply means the concentration of the antibodies, which refers to the reciprocal of the highest dilution giving a positive reaction with which provides now the measure the amount of antibody present in the serum. Kaya nga when you report it, it is in ratio itong titer. At 1 is to 200, 1 is to 400, 1 is to Anton. So that is how you express the titer. You consider the test to be significant if there is a four-fold increase in the titer or in the antibody concentration. Like for example, if we're going to investigate for if there is already adequate number of antibodies, so we usually collect two sample. One as the baseline reaction, which correspond to the time that the patient was still incubating the disease. Then the second pair of the setup is when the patient is already on the convalescent stage of the disease, and then you compare between the two from the initial and then the convalescent now period. If there is a fourfold increase, then you will label it as significant. Okay. So, with regards to agglutination, paraparawiyahan tiyahan precipitation. So, we have hemagglutination. So, we have the cold and heritofile agglutinin test. This time, it is called hemagglutination because you are using the red blood cell to show the reaction. Then we can have also bacterial agglutination. So it's the cells, microbial cells. So we have also the direct non-immune agglutination, like the viral hemagglutination. So this is based on the non-serological hemagglutinating properties of some viruses. So it is the characteristic of the virus that they are capable of agglutinating the red blood cells, like the influenza, the vaccinia, variola, dengue, mumps, Coxsackie group of viruses, and rabies. They within bagan instinct na haira property iton capacity to agglutinate the red blood cells. And then we have the indirect or the passive agglutination. Again, the soluble antigens are made to react with the antibody with the use of one carrier particles like RBC, latex particle, or colloidal charcoals. Okay, last topic for this, we have the complement system. So part of the action of your antibodies is through activation of the complement system. So what are the properties of the complement system? They exist as normal serum proteins. They are normal serum proteins. And there are at least 20 components, 9 major components designated as C1 to C9. So, since they occur in the serum, what are the cells responsible for each synthesis? So, they are synthesized from the epithelial cells of the intestine, macrophages, fibroblasts, and liver cells. They also circulate in the plasma in active forms. And when they are activated, they are converted into active enzymes. So there is a need for this complement system to be in its active form, because once they are activated, it will cause lysis of the cells. So dapat diri hira active originally, kay once they are activated, the end result of the complement activation is cell lysis. Okay, so being also protein in nature, they are activated at 56 degrees centigrade for 30 minutes, but they are destroyed. Though hitting them beyond 56 degrees centigrade. Complement is non-specific serologic reagent, and once it's not only its action concerned centered on lysis of cells, but some of the products of complement activation may have major roles in host defense, like opsonine production, anaphylactic activity, activation of inflammatory cells, lysis of target cells. So, and then since I mentioned it, that they occur as inactive proteins, so they need to be activated uh, for it to function. And there are two pathways of complement activation. We have the classical and the alternate. Actually, the two only differs kung ano nga na-start itong activation. Okay. In the classical pathway, of course, for the complement system to be activated, itong primary requirement ko din there is antigen-antibody complex formation. Magkamay-ada ng ngani, antigen-antibody complexes that are formed, it is now ready to activate the complement system. However, there are also other activators of the complement system. We have the lipid A of the lipopolysaccharides that are associated with microorganisms, the RNA retroviruses, the C-reactive proteins, dextrans, heparin, and even mitochondrial membranes. They may act as also a source of activators. Okay, so for the classical pathway of complement system activation, it starts with C1 as the recognition unit, and then the cascade continues up to the time that there is ultimate production of the membrane attack unit, which is composed of C5 to C9. In contrast with the classical pathway, the alternate pathway starts with complement number 3. So hakuan classical classical pathway C1, alternate pathway C3. So what are responsible for the activation of complement 3? So we have the polysaccharides, the bacterial components, viruses, fungi, parasites also, and even cobra venom factor. Amo iton hiya nga there is intravascular hemolysis in cases of kung nakagtan ka cobra. Okay, because of the activation of the complement system. Okay, so this is the complement system. Again, in the classical pathway, you start with complement component number 1, and then the alternate, you start with complement component 3. Okay, so you can during the activation of each component, there is the activation is characterized by cleavage of the complement component. So like for example, you start here with C1 in the presence of the antigen antibody complexes. So it will convert now to C1, activated C1. Maaram ka mo nga activated na kiya kay I don't know if you can observe, there is already a line drawn above the component. And then it is responsible now for in cleaving C2 to C2A and C2B. Tapos, so please take note na itong the cleave part, amula iton niyat na join iton process of complement activation. But the other half, may daton nira certain functions gihapon. Like for example, in this C2, ito na participate la is C activated C2A. In yung C2B, may dat niya ibang functions. Okay? So, ultimately, there is amo din hiton meeting point between the classical and the alternate pathway of complement activation here. So, amo iton iya meeting area. Once na reach ini nga area, there it will now cause the activation of the complement system up to the time that there is already formation of the membrane attack complex. This is the end product of complement system activation, the formation of membrane attack unit or membrane attack complex. Okay, so this is really the one, the MAC or MAU is responsible now for the lysis of the cell. Okay, so what are the biologic activities of the product of complement system activation? Primarily, cytolysis or cell destruction. So this is again caused by the membrane attack unit or the membrane attack complex, MAC or MAU. So cells that resist the complement activated cytolysis are the yeast cells, most mammalian cells, and most plant cells. Salit, we are spared, and most of the mammalian cells resist the action of your complement system. Pero may dalawat iba nga sensitive, like those that are naturally sensitive to the action of your complement This include the very important cells, leukocytes, thrombocytes, red blood cell. This is responsible now for the intravascular hemolysis, the destruction of the red blood cells. Okay, other functions like enzyme formation, like C1s esterase, then C3 and C5 convertase, and factor D. So, and then they may act also as anaphylatoxins, meaning they are involved in the anaphylatox uh, in allergic reactions, anaphylaxis. So we have the C3A, C4A, and C5A. And then we have the chemotaxin formed by your C5A, C3A, and C567. So this part of your complement, they facilitate the of the chemotaxis of the cells going to the area where there is inflammation or there is an infection. Then other biological activities, we have opsonization specifically related for C3b. Again, opsonization refers to the coating of the antigen so that uh, the process of phagocytosis is facilitated. Then we have immune adherence and virus neutralization. Okay? There is a need to control the activation of your complement. Why? Because it is destructive. And once it is activated, diretso na gutit hiya, it will cause cell lysis. So there is a need to control. So the two principal control system are the proteins that are responsible for its inactivation and inhibition. So they are referred to as inactivators and inhibitors. So these are also serum proteins and are complement components. Okay. So complement inactivators. We have factor 1 that it inactivates C3b and C4b. The factor H that accelerate the inactivation of C3b and C4b. Then we have the ANA inactive, that is carboxypeptidase enzyme that inactivates your C4A, C3A, and C5A. Then we have the C4 binding protein that prevents the activation, participation of the complement cascade activation. And then C6 in F specifically inactivates your C6. And then the complement inhibitors, we have the C1s I in H. So specifically, it inhibits the C1s. Then we have the S proteins that has the ability to bind surface lipids and interfere the action or the attachment of your membrane attack unit. So Derinira, it to some extent it offers protection for the cells to be destroyed. Okay, that's one. That's the last part ikaduha nga topic. Ano nat oras? Kaya pa? Panguwi na kita kay mga damo para makastudy ka mo. Do you have any questions?
Nag-clarification lang po, Dok, sa complement, Dok.
Sige, Cesar.
Sa complement, Dok, sa alternative tsaka classical pathway, Dok, at which point po nagko-converge yung classical tsaka alternative? Is it C3, Dok, or C5?
Ha?
Is it
C3.
C3 or C3, Dok? Wait,
Kasi 3B na pathway. Dito yan nag-merge. Pero ang the formation of the membrane attack complex or membrane attack unit, dito na start ha C5. Did you understand? Did you get it? What about the others? Nakuha niyo to? And di ba, the complement system activation, there are two, the classical and the alternate pathways. So they only differ han start nimo han activation. The classical starts with C1, the alternate pathway starts with C3. But then the two pathway activation will merge each other at the level of C3B, wherein there's already activation of your C3. Ato dito matik ang naha C3B. And then, ang papakianan ng Cesar, ang C5, dito na maka-start hand formation, hand membrane attack unit, wherein it is joined by the C6, C7, up to 9. That's already the membrane attack complex or membrane attack unit. So, amo na tiyak responsible for the lysis. Okay. Other questions? Ay, kamo pag prinoblimat pharma la ito. Siyempre, ano nagsering na iyo, it is still a period of adjustment. Oo. Dili pa man kamo maaral its style. Nako. Other questions, Moray? Ano at oras, mga alas 10 na. Ano man, tapuson tanan na niya para gihapon makag-test gihapon kita. Sunod. Actually, the last topic is about hypersensitivity reactions as a result of the activation now of the immune response. Kamo lagi niyan makakapoy na kamo. So diyan na kamo mamati akon kay wala gud kamo mga turog. We, storya he. Kinatulog gag kamo. Pamati ko na unang pangalan kang pagkaturog kontra ako kay ako nangaturog ako alas 11:30 pa waray pa kakaturog kay nagihin mo akan iyo exam. Basta masayo na lahat iyo pharma. Okay? Naka-relax na kita. Last topic. Eh, para kita makag-exam. Don't worry. 61 slides man na niya. 61. Okay. Hypersensitivity reaction, the last topic. So, before we discuss different hypersensitivity reactions, we have to define first the following terms. Diba? What gumawa si identification ni Dr. Esquivel. So, immunity refers to a state wherein there is prior contact of a person against an antigen obtains protection that would otherwise harm him. So the reaction is said to be specific for the particular agent and the benefit comes from the immune setup. So that means during the initial contact with the antigen or the allergen, you are still asymptomatic. Ha? Ang first contact nimo itong antigen or the allergen, you are still asymptomatic. Waray pa nimo mga simptomas and allergic reaction because it is the initial contact. Okay? So, the first contact will serve as your sensitization phase. Okay. So, allergy or hypersensitivity refers to altered reactivity to an antigen which can result in pathologic reactions upon subsequent exposure to that particular antigen. Again, the key word here is subsequent exposure. Subsequent exposure. Okay, an allergen is referred to as sensitizer. So the antigenic substance that can trigger the allergic state. So it is protein in nature or non-protein of low molecular weight. Okay, so these are the different entries of allergens into our body. The most common is respiratory tract. Okay, respiratory tract. Itong mga makakabaho ba, like for example, itong may para ira mahamot na hira pero hai mo bagan offensive baho, di ba? Iton kuan iton iyara pahamot na mag-isog na pag kuan nimo develop na imo allergic rhinitis kay maginat singon ka na kuan. Labi na kung you don't like the scent of the perfume or pahamot tit imo ini sangkay. Masaling ka na agi, ano tin pahamot? Baygon or Lysol na scented. Okay? Then another is through injection which is dangerous kay once it is injected, direction na ito and then digestive tract. So niya mostly mga food. Like for example, some of you may have allergic reactions to seafoods or ano pa nga mga pagkaon. And then skin contact, like this one. Maybe this baby had allergic reactions sa diaper. Okay? So those are the routes of entry of allergens. So we have classes of allergic responses. The immediate type, it is called immediate type because the reaction appears within minutes from exposure, 20 to 30 minutes. So after intracutaneous injection or cutaneous application of allergen. So usually this is mediated by antibodies, specifically immunoglobulin E. The delayed type is said to be a slow response. Usually it takes about mga 1 to 2 hours. 1 to 2 days. So this is cell-mediated reaction. So delayed. So we have 4 clinical types of allergic reactions. Type 1 is anaphylactic type. This is immediate and this is said to be the most common. The second type is cytotoxic type. This is due to the toxic effects of anti-cell and anti-tissue antibodies. So this is facilitated by antibodies. Itong type 2 gihapon. The type 3 is complex mediated type. This is due to the toxic effects of the antigen-antibody complexes that are formed. And the last one is the cell-mediated type. So, on first two reactions, allergic reactions, are antibody-mediated. And type 3, it is complex-mediated type of allergic reactions. This complex refers to the antibody and antigen complexes form, whereas the type 4 is the cell-mediated one. Type 1, hypersensitivity reaction. Again, this is mediated by immunoglobulin E bound to mast cells and basophils. So the reaction results from the release of pharmacologically active basoamines. So antigens, which are potent stimulators of this type of hypersensitivity reactions, include pollens, helminth antigens, proteins from insect venoms, helminth antigens. So, ano nini? Finding, nasa inimasaling ka nga, di nakakaintindi ako, dali lang nag-allergy, namumula. You might as well submit yourself for stool examination. Kay bangin damot imo mga wati. Tapos itira mga waste products. That's the one that causes you the allergic reaction. Ha? Val, pagpahisamin na imo tae, kay bangin ang matutuan. Damot imo parasites. Okay. And another very characteristic for type 1 hypersensitivity reaction is genetics. So this is the most important factor that influence the development of allergic reaction. History of exposure within the family, the EU genes. So be careful iton kuan. You should ask your partner kung may niya history in allergic reactions kay mahal itiya nga uyab kay ditiya nagaagwantahin mga kuan na baratuhon nga jewelries nga nakaka-allergy. Imagine makuang ka na. Mag-i-invest ka gud haiya. Diti masudutin in pulseras or ring na tag pisola or ang tinudtod na bain chingko. Okay? So, may the history. So, what is the genetic basis for this? There is a major IgE regulator locus that influence the overall IgE production probably through T-cell mediated mechanism. So there is an association between these certain HLA haplotypes and the occurrence of atopy. So the LR gene of the HLA region influence the allergic trait of the individual. So be careful, may the genetic basis. Okay, so what is the mechanism behind the development of anaphylaxis? Laxis. So we have the susceptible person, which is you. So you are exposed now to the antigen. And then upon exposure to the antigen, there is an immunoglobulin E production, and this is attached to the mast cells and the basophils and the dada. Upon re-exposure to the same antigen, you become now a sensitized person, because you have a previous history of exposure. So, ano't mahitatabo upon re-exposure for the same antigen? There could be now antibody reactions leading now to the degranulation of the mast cells and basophils, releasing now these vasoactive amines, namely your histamine, serotonin, leukotrienes, your prostaglandins, the eosinophil chemotactic factor, the platelet activating factor, the NCFA, and the kinase. So those are just examples of the vasoactive amines that are released once the mast cells are degranulated. So this one. So we have the allergen, and then we have the macrophage, the antigen presenting cell that phagocytose and processes the antigen. And then the antibodies attach. So we have this following cascade of events up to the time that there is mass sensitization. And what happens after? Amo na niya. Upon subsequent re-exposure to the same allergen, it will now cause degranulation of these granules, releasing now the vasoactive amines. Okay? So, amo na iton hiya ang na-explain of the signs and symptoms of allergic reaction. So, what are the biological effects of the vasoactive amines released by the mast cells? There is increased capillary permeability. Amo ito may allergic reaction, imagine na nala it imo self kung may dani mo history of allergic reaction. Because of the increased capillary permeability, there is now the leakage of fluid causing now edema. Naghuhubag na iting naong. There is vasodilation, contraction of the smooth muscle, especially that of the lungs. So nagkakamayanan ka ng wheezing. Nagkakamayanan ka na difficulty of breathing. And then migration of the PMNs and aggregation of the eosinophils. Okay, so clinical manifestations, you can have systemic and local anaphylaxis. And systemic ang makaradlo. Okay, it can cause loss of consciousness and swelling of the tongue. So pwede tiya makakosin obstruction in to swallow. And then and swelling pa of the throat tissues. Then urticaria, so like this one, pamumula, iton iya wrist. So this is secondary to kuan in fake nga bracelet. Okay, you can have also bronchial asthma exacerbation brought about by allergic reaction, allergic rhinitis, and yung neurotic edema, nanuhubag, please take note, naghubag aniya naung, and then those are the clinical manifestations related for hypersensitivity reactions. And the culprit is this cell, the mast cells. So what are we'll just run through these different functions and the chemical mediator of hypersensitivity reaction. Of course, ang pinaka-starring, histamine. So what are the effects of histamine? It causes dilation and induction of increased permeability of small blood vessels. So this is responsible for the wheel and flare reaction na mumula. Then there is smooth muscle contraction, so causing now obstruction in the na causing na wheezing sound bronchial tree, tapos you can have diarrhea also or contraction of the smooth muscle of the uterus and bladder. It is a potent stimulator of exocrine secretions. So aside from bronchoconstriction in asthma, you can have increased bronchial secretion, then gastric lacrimation and salivation. So enhances the response of basophils to complement component C5a and promotes helmithicidal activities of eosinophils. And also, histamine is a chemotactic for eosinophil, adding more injury because of the degranulation of your eosinophils. Next, we have serotonin. It has an activity in your heart by stimulating the heart, causing now a rise in your blood pressure. And please take note that the serotonin can also be produced by the platelets. Then factors derived from the arachidonic acid pathway. So what are these factors? We have the leukotrienes. So we have the leukotamine B4 with causing stimulation of your neutrophils and eosinophil chemotaxis. So recruiting the cells to the area wherein there is the antigen. Then we have the uh, leukotriene C4, D4, and E4. So this is referred to as your SRSA or the slow reacting substances of anaphylaxis. So it can cause increased vascular permeability and provoke slow contraction of smooth muscles. And then we have the eosinophil chemotactic factor of anaphylaxis. This is responsible for the recruitment of the eosinophil to the area where, again, there is antigen, and upon reaching the area, it will cause now degranulation, releasing important substances. Then we have the TAF or the platelet activating factor. So it will cause now aggregation and release of the platelets of the serotonin. And also it favors prostaglandin synthesis and promote also neutrophil aggregation. So adding injury to the uh, to the patient. So other biologically active factors, we have the neutrophil chemotactic factor of anaphylaxis, the neutrophil immobilization factor, heparin, and the kinins. So we have bradykinin. It causes increased vascular permeability, and then it stimulates the smooth muscle contraction. So types of anaphylaxis in humans, again, there are two types. We have the local and generalized. Mas dangerous ito generalized. Okay, so it usually begins 20 to 30 minutes after the exposure of the inciting agent. So the manifestation of the patient may be urticaria, wheezing, paroxysmal coughing. So the patient may have dyspnea, cyanosis, vomiting, circulatory collapse, and the patient may be in shock. So what are the different causes, mga culprits? So you can have drugs like penicillin allergy, so some
Wow.
biological products, then food like seafoods or chicken, then causes of death may be due to laryngeal edema, massive airway edema, and cardiac arrhythmia. So it may be the cause of death would be arrhythmias. So that is the generalized anaphylaxis. Then we have also the so-called localized or spontaneous uh, clinical allergy. So this begins few minutes after the contact with the inciting antigen, usually through inhalation or ingestion. So signs and symptoms may include hay fever, urticaria, asthma, or vomiting. So please take note that there is marked familial disposition in this. So again, family history. So cross reactions between unrelated antigens are frequent. So pwede magkamay-ada cross reactivity. Dili not necessarily an initial na inciting substance. Okay? So localized anaphylaxis may be like this. Urticaria. So you can have cutaneous anaphylaxis. So this is exemplified by skin test. So here, if the patient have allergic reaction to that the drug that is being tested, there could be whale and flare reaction like this, naghubad. Okay, diagnosis is through direct allergen skin test. So you can have epicutaneous or intradermal. Then you can have also oral or inhalational test of allergen. And then we have the wrist and the RAS. For the wrist or radioimmunosorbent test, this test the total immunoglobulin E concentration, whereas the radioallergosorbent test, this refers to identification of specific immunoglobulin E concentration. So unrest is total, whereas the RAS is specific IG concentration. Then you can also do the Prosner-Kostner reaction, in which the serum of allergic individual is injected to non-allergic individual. So after 1 or 2 days, the antigen is injected to the site of serum injection, and then take note for the occurrence of the immediate type of hypersensitivity reaction. So that is your Prosner-Kostner reaction. It is an in vivo test. Then there are also cases wherein we can have as allergic like reaction, anaphylactoid reaction. So it is not an allergic reaction, but only resemble to that of the anaphylactic reaction. So this is observed following injection of colloids or finely suspended material in the bloodstream. So there is no involvement of the specific antigen or antibody. So because of the presence of colloids, it will cause liberation of vasoactive substances as a consequence of colloid reaction. Anay nga kay naglulobot na ako, kuan laking akong charger. I'm back. Okay. Nangangaturog na kamo? Hapit na kita mahuman, don't worry. Mahumang gihapon, magkakag-exam gihapon kita Monday. Okay. Nagahang po. Okay. So do you have any questions with regards to the type 1? I'll proceed with the type 2 or the cytotoxic type. So this involved the interaction between the antibody and with either an antigenic component of the tissue or an antigen or hapten which has intimately associated with the tissue cells. So here in cytotoxic, this involve antibodies reacting to tissue or organs. So the antibody is circulating in the blood, and this may be they involve immunoglobulins. We have the gamma and the mu. So this require presence of the complement to effect the cellular damage. Okay, so this is the type 2 hypersensitivity reaction with the involvement of the complement system. Okay, so what are the mechanisms of tissue injury in type 2 hypersensitivity reaction? So the first one is reaction to antibody with tissue cells. So the antibody induces direct cytolysis and killing by activation of the complement system. So this is special true in hemolytic reactions, meaning the antibody circulating in your blood plus the activation of the complement system, so will cause now destruction of the red blood cells, causing now hemolytic reactions. Another mechanism is involved the participation of such cell as neutrophil and macrophages. So it is the presence of the antigen antibody interaction that stimulates the neutrophil and the macrophages. And then the third is reactions against specific receptors on the cell. Like for example, in myasthenia gravis, there is the presence of antibodies against the acetylcholine receptors. So, these antibodies um, causes destruction of the receptors so that the acetylcholine neurotransmitter will not be able to interact with the receptors. So the expected effects of acetylcholine will not be expressed. And the last one is inactivation. So examples of type 2 hypersensitivity reactions are the isoimmune reactions like transfusion reactions, the Rh incompatibility or the hemolytic disease of the newborn. So most of you here are aware of this, especially the nurses, and then organ transplant rejection. So here, this is an example of this an an Rh incompatibility. So here what is involved is gram negative mother with an Rh positive fetus. Initially, there would be no reactions that will be uh, during the first pregnancy, there would be no reactions that will be observed. Kay baga, and first na pregnancy will just cause the sensitization of the mother. It is the subsequent pregnancies that are affected by Rh incompatibility because the mother now will because of the exposure to the Rh positive fetus, the mother will be forming antibodies against this Rh antigen, so that the subsequent exposure or pregnancy, the antibodies formed by the mother will destroy the baby now. So there would be the anti-RH antibodies crossing the placenta, destroying now the cells of the fetus. Then we have the autoimmune hemolytic anemias and Hashimoto's disease. The Hashimoto's disease is um, there is formation of antibodies against the thyroglobulin molecule. So this is Hashimoto's thyroiditis. It is there is enlargement of the thyroid gland. Hey, yes, hapit na kita. The third type is the complex mediated hypersensitivity reaction. Here, it iulad I mean dapat mabaruan here is because of the presence of the antibodies and the antigen complexes formed, it is the one responsible for the destruction. So cells or tissues are injured because of the complexes that results from the interaction between the antibodies and the antigen. Okay, so this is the schematic representation of cytotoxic or the third hypersensitivity reaction. So we have here the antigen cause reacting now to the antibody. So the reaction will form now the antigen antibody complexes. These are the complexes that this causes destruction of the tissues. So this will be phagocytosed initially by the phagocytes. Okay, but some of these, so may naton defense mechanism ini aton lawas. So some of the complexes are cleared from our body by these phagocytes. However, the remaining complexes are retained in our body. So these complexes will activate the complement system, will activate the complement system, and maaram naman kamo once there is activation of the complement system, ano't may tatabo. So the antigen antibody complexes and activated complement will attract the neutrophils, which are now responsible for the release of inflammatory cytokines, causing now damage in the blood vessel wall. Okay, so again, to review, the first thing that will happen is antigen antibody complexes formation. Initially, some of these complexes are ano are taken by the phagocytes, but some of these complexes are retained in our body. That will cause now activation of the complement system and as well as the neutrophils. So because of this, there could be now tissue injury that will happen. Okay, so what are examples of type 3 hypersensitivity reactions? We have the Arcus type of reactivity. So the antigen antibody complexes precipitated in the blood vessels. With this will cause release of proteolytic and lysozyme enzymes by the phagocytic cells. So it will cause now damage in the blood vessel walls, causing now hemorrhage, necrosis, and increased vascular permeability. Okay, so that is an example of Arthus reaction. So the requirement here is there is influx of neutrophils here for the for the tissue damage to be observed, because it is through the release of inflammatory cytokines that are responsible for the pathology of type 3. Okay, so other reactions na type 3, lupus, arthritis. Okay, so those are samples. Ay, salamat. Last, we have the type 4, or the cell-mediated or the delayed type hypersensitivity reaction. So this is based on the interaction of the antigen with the primed T cell. So this is cell-mediated. So the manifestations are due to the release of the lymphokines by the activated T cells. So this involves formation of induration and erythematous reactions, uh, 1 to 2 days. So histologically, there would be now infiltration with nuclear phagocytes and lymphocytes, and characteristically, there would be granuloma formation. Okay, so what are the mediators of the type 4 hypersensitivity reaction? So we have the migration inhibiting factor, which is inhibitory to the macrophages. Then we have the leukocyte inhibiting factor, which causes inhibition of the random migration of neutrophils. Then we have interleukin 8, which is known as your macrophage chemotactic factor. And then interleukin 2, that stimulates the T cells, the growth of T cells, and activation of cytotoxic lymphocytes and macrophages. Then we have tumor necrosis factor beta, which is responsible for the lysis of tumor cells. And then we have the macrophage activating factor that are responsible, that are these activating factors for macrophages are in the form of interferon. Then the macrophage granulocyte colony is stimulating factor, and the tumor necrosis factor alpha. So they are responsible in mediating the cytolytic and microbicidal activity of macrophages. Okay, so these are the different types of type 4 hypersensitivity reactions and their characteristic appearance, clinically and histologically, and what are the antigens involved. So we have contact dermatitis, the tuberculin reaction, and some granulomatous reactions. Okay. Okay, hapit na. Okay. So the following slides are examples of type 4 hypersensitivity reactions. So we have contact dermatitis. Contact dermatitis. Wow. Are you aware of this? This individual develop hypersensitivity reaction to the rubber inserted to this thing. Nagamay ada hiya reaction and condom. Okay? So, para't mga rikuhano, nagkakamay allergy, iton mga fake na mga bracelets. Okay, leprosy. Then, tuberculin reaction. It's also one form of delayed type. Okay, hi, salamat. Thank you. Ay, maunga-unga. Mga may kala. Makapoy mang panginabuhi. Do you have any questions? Now manggiya pan lecture. Hangganan usa ka semester nga subject. Do you have any questions? Uy, pag kita, you ask questions, God, kay para, di ko rin kasayang ang pagginaw-yaw. Naintindihan la? Or napipirit na la? Or excited ka mo exam niyan? Pwede kita 1:30 na lat exam? 1:30? Honestly, waray pa ako. May dana na naka-receive ha iyo email? Hit exam? Waray pa, no? Kaya waray pa ako mag-login. Kaya waray ko, debe pa nga ni human it set for. Mamay, ginuhuyam na hi Queen. Do you have any questions? Waray? Ayaw laan ni kamo pag binanunaw na pharma. Kaya expected la ito nga may dapa ito period of adjustment. Waray question? Yes. Is there a way to combat the incompatibility in the second pregnancy? You are talking about the RH incompatibility? Yes, there is a way, the truth and the lie. Actually, may da. Maging bisan ako, may kato na. Actually, di ba, the first pregnancy involving RH incompatibility, safe pa itong pregnancy because it is during the exposure itong nakaka-cause sensitization, formation of anti-RH antibodies in the mother. You can inject a preformed antibodies destroying the RH positive cells in the mother. After the pregnancy, after the delivery, you can inject ROGAM. So, actually, there's no problem with Pinoy. Kay we are RH positive. Kunit atong partner, Pinoy lalagi hakon. Kay mga ambisyoso naman kamo, nagkikinukuha kamo mga AFAM. Nagkikinuha kamo mga Caucasians. Salit, gakamayanan na kita mga kuan. So, ito ng mga RH, negative ng mga kuan tao. So, ano't na itatamo? Pag-asawa kung RH negative ka, pag-asawa Henrico, kay kada pag-aanak ni mo, ma-inject kan ROGAM. Okay la iton hiya. Ayo pagpangitahin para uma. Kay dere iton makaka-afford in ROGAM. Or pangitan na lahin kuan kasi Pinoy. Kay imo punduhan na eksakto lat ka ng Pinoy. Ayaw ka mo ito mga AFAM, ay magugulat guliat ka. Kay na kuan na heet siringang taga Eastern Samar. Na heet salit kakuntinto na net Pinoy. Waray panimo risk in RH incompatibility. Na oo, he's charming. So, sumatay ko ka ni ma'am. Okay? So, did I answer your question, Dr. Argil? May dagad remedyo. So, you can inject ROGAM. This is for the purpose of destroying the Rh positive cells that are retained after the delivery. Kay para safe na luwat ang imong pagburod for the succeeding pregnancy para to inhibit the formation of anti-Rh antibodies. Okay na? Are you convinced, Argel?